Hello. This is a presentation that I gave earlier this week to a group of visitors to Eldoret, Kenya, visiting AMPATH. The specific presentation was supposed to be on the capabilities of our data and dashboards here in AMPATH, but in order to understand our visualization of data, we have to show, I would think, where the data comes from. And so it ended up being also a comprehensive presentation on the AMPATH Medical Record System, AMRS. And I'm recording this presentation again so that we can share the history of the AMRS system with new members to our AMPATH development team. My name is Gregory Schmidt. I'm an internal medicine physician in Canada and interested specifically in how we can design better healthcare systems, and particularly believe that technology, and specifically the electronic medical record, can play a crucial role in expanding access, improving quality, and reducing the cost of care. And I have the privilege to share with you now the work which our team has been doing towards this here in Eldoret. And for full disclosure, I have not been in Kenya for more than 3 months. And so whenever I speak of the word we and the cool things that we are doing, I have had nothing at all to do with this. This has really been driven and developed entirely by our team here in Kenya, and I want to really underscore that fact. The two other people which should be introduced, on the left you can see Dr. Jonathan Dick. He is a physician from Indiana University and the Regan Street Expert Institute, an expert in health informatics, electronic medical records, and internal medicine. On the right, we have Nikki Kibana, who is our head of development and lead programmer on the system. And the two of them have really made what we're going to see here today possible. And so let's move into part one here on the evolution of the AMPATH medical record system. We'll start at the beginning. At one time at AMPATH, years ago, there was obviously just one patient. And it clearly was easy to take care of just one patient. All you need is a folder. And in that one folder, you put some notes from today's encounter, some notes from their past medical history. You probably also should include the note from the nurse, the social worker, the nutritionist, the dietitian, and the outreach worker. We'll also include the nursing vitals and the physician examination. And we'll put their current medications, their past medications, their allergy lists in as well. We'll add their viral load, their past viral loads in there as well, and we'll add their chest x-ray from last week. But actually, wait, the chest x-ray looks like it came back positive for tuberculosis, and so we'll add in some more medications to the file. There we go. Oh, and actually, all we have to do now is keep track of when this patient should return, when they should repeat their blood work, when they should repeat their chest x-ray, and because of the fact that we have sent a request for dermatology to look at a Kaposi sarcoma, we're going to have to make sure that we follow up when that consult comes back. And if the patient forgets to come to a clinic appointment, our clinic has to know the exact next day that they missed their appointment so that our retention nurse can get on her motorcycle, drive directly to the patient's house, and try to follow up with them to find out if we can retain them in care. As you can see, there's actually a lot of data which we have to manage for one single patient for one single encounter. And that's for HIV, which is realistically actually a pretty straightforward disease to diagnose and has a pretty sequential treatment pattern. I don't know if anyone has ever tried to manage their own personal health record or that of a family member, but my understanding is it's a surprisingly large challenge. And this isn't entirely surprising because, as I tell my friends often, the only difference between medicine and sorcery or witchcraft, both have very nice people, very caring people, people that want you to get better, but the only difference between these two is that medicine runs on data. We believe that the treatments we have and the diagnosis we have are evidence-based, backed by data. And so in reality, we're dealing with the data field, and we need to have a system which can reflect this. Now, AMPATH didn't wait in their tower for patients to come to us. They went out and found patients. And so, imagine now managing the data for 1,000 patients, for instance, or for 5,000 patient records. These are actually some pictures of rooms which they keep at least 5,000 records in those clinics, and it's a pretty big undertaking. And imagine having to file these charts and then pull them out to add more labs, more meds as those become available, and then have to return the file and get them for clinics. It's a huge undertaking. But we're actually not done, because if we wanted to produce a report, we have to now turn to these. I'm not sure if anyone's seen these before. These large books on the tables, but these are, you could imagine, 8-letter words, or actually I'm not sure how many letters are in the word registers, but it's not something to look on fondly. A register, as you can see, is a book with the table inside where you can write the patient's demographics across the first few columns. You have to write their name, their age, their date of birth, their gender, and their ID number, of course, in every single register. And then across the other columns, you record several particular pieces of information which are related to that register. Now, the problem is that it's not uncommon for a patient to come into clinic and actually have to have not just 1, 2, or 3 registers filled out, but perhaps 5, 6, 7, or more. And all these registers then produce different reports. And with all this data which is entered into the register, in the end, typically, just 4 fields at the bottom, or maybe a few other fields in the bottom corner, are actually summed from that entire register page and then fed up higher into the data management systems. And so there's quite a lot of data which is repeated and which is lost and never captured. If you ever wanted to go back and actually get to the original data in those registers, good luck. Because this is a picture of the world before electronic medical records. Or perhaps this is after the electronic medical records came in. But, it's a sad picture. Think of all the data, all the valuable information, which is just gone to waste. And more importantly, think about how hard it is to answer the question in this pile of patient charts. Who are the 11 patients which missed yesterday's appointment? Which are the 337 patients which should have their HIV viral load repeated because they're past the deadline of repeating and their past viral load was too high? It's really hard to answer these types of questions in real time when you do not have an electronic medical system, which is a real-time system. And these are the types of questions which you need real-time data to properly deliver healthcare. I was in Turbo County earlier this week with Dr. Lactabai, and he has finally found a use for paper registers and paper medical records. We can see it here. You can use it in this incinerator to cook your lunch. And so the story of the AMPATH medical record system has been a story of continuously working to improve our data and improve our data specifically for the purpose of providing better care. So why don't we start here on the historical founding? From the start, AMPATH realized the value of an electronic medical record system. And so in the very early years of the program, back in the very early 2000s, there was a Microsoft Access database, and paper records were entered into this. But by 2004, AMPATH had grown to 3,000 patients, and it was anticipated that it was going to go under an exponential growth in the next 1 to 2 years. Now, I asked in the presentation earlier this week if people in the audience could estimate how many patients they thought AMPATH was going to grow to from 3,000 into the next 1 to 2 years back in 2004. And, people threw small numbers around. But the answer was they were expecting to grow by up to 30,000 patients. And so their Microsoft Access database was stretched to the limits. In fact, the number of columns in the database had maxed out the number acceptable in Microsoft Access. And so they were on to their second and third data tables. And therefore, they brought in experts in informatics from the Regenstrief Institute in Indiana. And so they brought in Paul Beyondich and Burke Mamlin, who were both physicians as well as electronic medical record experts, to look at the problem. And now the Regenstrief Institute that they came from was built and founded years ago by Mr. Sam Regenstrief, who is an expert in systems efficiency and also known as the dishwasher king. And he used his fortune from dishwasher selling to found an institute specifically with the purpose of applying systems design and informatics into healthcare to try to understand how we can build a better healthcare system. So Paul and Burke come to Eldoret, Kenya, and it is immediately apparent to them of the enormous scale and challenge that they're up against in the battle of HIV. Knowing that they can't do this alone, they look out to the global community and find some partners. To begin with, Partners in Health was facing similar challenge as they were trying to scale their electronic medical record system, which was being used for HIV care in Haiti, as they moved to scale into Rwanda. They also found partnerships with the South African Medical Research Council and the Millennium Villages Project. And this global team worked for 2 years, and by February 2006, the first instance of the OpenMRS system was launched. This version of OpenMRS running at AMPATH was called the AMPATH Medical Record System, AMRS. In the coming years, a global community would grow around OpenMRS of collaborators. They would have support from the Google Summer of Code for over a decade, and today OpenMRS is in over 80 countries. It's a really remarkable story of a product which is now worldwide, but came out of initially a need here in Eldoret. Let's move into now looking at this first system used. Here we have the early login screens, and the workflow went like this. A paper chart and a paper form was filled out in the clinic. The paper form was then transported to a data entry facility, entered retrospectively into the computer, as you can see, using a product which looks very similar to the form itself. Then the original form was transferred back to the clinic to be refiled into the patient's chart. And also, in theory, the computer would print out a patient summary, which actually looked pretty nice. You have some past history, some past lab data, even some clinical reminders. And then this paper summary also had to get into the patient chart, and all this process had to be turned around before the patient came for their next HIV visit, which easily could be perhaps a week, a few weeks, or maybe a month. And the problem was that the paper summaries in the patient chart were often getting out of date and therefore not being particularly usable. The other major challenge is this early system was connected through a satellite microwave network, and you of course need point-to-point communication for this, and the system could often go down, and the upkeep to make it work again was time-consuming. So why don't we go fast forward in time? As I said, the system was initially developed in around 2006, and then throughout the 2006s all the way to 2015, we have two major advancements. First, smartphones become popular, tablets are invented, and tablets become affordable. The second is that cellular communication becomes widespread, and Kenya leads the world with the implementation of cellular networks. And now that we had cellular connection and that we had tablets that were affordable, the idea of developing a real-time point-of-care medical record system was feasible. But there were some challenges. First, a reliable power supply had to be created at the clinics. Therefore, solar was installed on the roof of the clinic, connected to a battery underneath. This solar system powered the antenna, which we can see here, which is a cellular 3G antenna connected to Safaricom, and ultimately also powered the router system inside of the clinic. The router would distribute the signal to the different tablets and devices in the clinic. This connection through the Safaricom network would be wirelessly transmitted over an encrypted secure VPN line directly to Eldoret to our server center. This is a biometric protected, temperature regulated environment where we have our central brain and central hub for the entire system. Now, the first pilot of POC was run in October 2015. It was a horrible disaster. People hated it, but with some tweaking and improvements, within 4 months, AMRS was rolled out into the first successful pilot in Burnt Forest in February 2016. And then, since then, in just over 2 years as we have now, the team has been to work. The system is now used 6 days a week, and there are over 500 unique visitors. It operates as a live point-of-care system at 25 high-volume sites, serving 61,000 patients, and it's used as a retrospective data entry system at an additional 34 low-volume sites. Now, these are some interesting numbers. How many visits do you think are currently recorded in the system? We have almost 8 million encounters logged. And if you were to try to guess how many discrete clinical questions have been asked of patients that we have, discrete answers recorded in the system, the answer is 250 million. And so you hear about other people talking about big data. Well, we have big data here at AMPATH. Now, I'll be the first to admit the system is not perfect. There certainly are things which can be improved. But it is remarkable how much has been done in a reasonably short amount of time. And I just want to sort of clarify how this worked. OpenMRS remains our base layer. It's how we store the data, and it uses a lot of the underlying functionality which runs this electronic system. On top of it, though, the actual system that users interact with is an entirely custom layer which our team has built out just in the last few years, built in Angular 6. It runs in the Chrome browser, and that's how we deliver the system to tablets, to desktop systems. Now, I think it is important and helpful to imagine or to understand the team that runs this AMRS system. And this here is a picture of our team last Friday at the Sprint demo. The team we probably need a bigger room. The team really runs exactly like a Silicon Valley startup. It uses a sprint methodology or agile methodology where we have a gathering at the end of every 2 weeks of work, and we show the new tools which have been built out. New projects start with our project managers, and our project managers one is assigned to each department, such as HIV or chronic disease or oncology, and they really get to understand the users in that department, their needs, as well as they work with that department's leadership to build new clinical integrations and products. The project managers, then after creating mock-ups and getting consensus from the users, translate that to the developer team, and we have an amazing team of very talented developers. We have the senior developers who usually have attachés, which are university students in training who are mentored by senior developers, as well as we have interns and junior developers. We're actually very fortunate to have just last week hired another 5 interns, which is always really awesome. Now, once we have a product, we also have a forms and concepts team, and they build a lot of the forms, which we'll see a little bit later in the presentation, that drive the clinical encounters. All of this is checked upon by the quality assurance team to make sure that there are no bugs. And then it goes to the implementation team, and they produce the release notes and communicate updates to our users. The implementation team is also an incredible education squad when they go into new sites to set them up with POC. Users who have questions or are in trouble can contact the help desk by telephone or text message, and all users are always encouraged to use the feedback button inside the application to directly communicate to our project managers with new ideas. None of this would be possible if it wasn't for the network and IT team that install, monitor the entire system of routers, cellular connections, servers, and hardware. Now, this system here ends up producing quite a lot of data. And so we have a data and analytics team, which is working in conjunction with the ministry, with management and evaluation, to produce the necessary reports for the Ministry of Health, for the government, for donors, and for our own internal clinical uses. I'm incredibly proud of the AMPATH medical record team. It is amazing the system that they have come up with in such a short amount of time. They are an incredibly dedicated group, and they're always working to improve themselves, such as taking night courses in project management or in informatics, and trying to level their own skill set up so that we can continue to try to work to build something which really has an impact on HIV care here. Now, why don't we go ahead and boot up the system and see how it works. The system, as I said, works on tablet or desktop. And this was a screen capture I captured a little bit earlier in the week. And the thing I want you to keep in mind when we watch it is that none of it's sped up. It's all in real time over a wireless connection. I think I actually was going through my cellular pairing on my phone when I recorded it. You essentially open up Google, you launch it like a website. The website itself will load, and then you can log in just like any other system. I'll just log you in here. When you enter into the system, this is just a test patient. You can search for patients using any of their identifiers. You can also register patients from this page. Now, this is a test patient, so the dashboards aren't loading properly, but we have on this page dashboards which show summary information about all the patients' programs they're enrolled in. You can go up to the patient information if you need to change their demographics or contacts, address or identifiers. We can link accounts together through relationships. And we upload here an outreach locator map so we can always find the patient if they don't return to care. Now, what I would like to do is go back here and load a patient's chart, which is a real patient, which we've completely de-anonymized their information so that you can't recognize them. But it's useful because you can see how the system works. Here in the bottom right and in the top, you can see that the viral load reminders have appeared to help nudge the clinician in the right direction. We have lots of reminders, such as when patients are eligible for new programs or when they should have follow-up booked. We also have in the middle a patient summary of the information which the clinicians want to see right when they open the chart. You could open up that program and see further summary information which has been designed based on the most important information to the clinicians in time, such as medications and clinical summaries. And you see here the ability to export the entire patient's summary as a PDF document in case they need to transfer to a site outside of our clinical care. We can also go in and look at other items such as visit. And this is a kind of a cool page. What you'll note is that the between care visit is the type of visit which is suggested. And that's because the system knows that I am currently at Moy Teaching and Referral Hospital. And this is not the patient's standard clinical location. And so because it knows the patient's not at their normal clinic, it's displaying the form which you may use if they're at an alternative clinic. And so it configures these forms based off of the patient's age, gender, program that they're in, as well as other factors such as location. And so they're pretty sophisticated. And the reason for that is that the system needs to be designed to be as intuitive and simple for any user to use and to make it easy to do the right thing. And that's because it's being deployed on quite a large network. And the reality is that some of the users actually are clinical health workers or people with minimal healthcare training, and we want them to be able to take care of patients and really use the system to level up their skills. We'll come back and look at the form a bit later in the presentation. We'll open up now the vitals, which can be viewed on the page such as here. You can also view a summary monthly status or a list of their current labs. And as you can see, we're actually currently renewing this entire lab display just because it's grown over time that the previous display doesn't work as well. And I want to show you something which is really cool. If we go here to the sidebar and go to the bottom, you'll notice there's something called imaging. This tab is brand new. It's only been rolled out in the last few weeks. But you can now pull up x-rays, which were done on our x-ray truck, see the report, and even view the image. And this is a fast x-ray to load. Again, this is all real time, nothing is sped up. And you can actually compare images if you want. In the future, we'll build in more advanced capabilities to zoom in and annotate the images. But this is a really nice feature which has been introduced just in the last few weeks. I'd like to move on now and load up a test patient and specifically go and see what it's like to look at a patient visit form. Now, when we load this form, it will take a few seconds or a prolonged period of time, and this because it is probably the largest form in our database, the adult HIV initial form. This form has validation info in it so that the data is congruent with itself and with past data. It also can make recommendations such as medications and follow-ups. There's quite a lot of advanced skip questions, as you can see inside of it, which we'll see when it loads up. It's a great form. And the other great thing about the form builder and concepts team is that it's a scalable model. In order to create these forms, you need a small bit of technical coding, but you don't need to be an advanced computer programmer. And this allows us to take users, provide some introductory training, and then each department can have its own team which builds and manages their forms. And that helps us scale this model of medical records. And so once a new department has been built into our medical record system, all that department needs to do is build new forms on their own. And we don't have to use developer time in order to configure and change the programs for that perspective. The system has really been designed mostly to operate on a touchscreen environment, although there are a lot of desktops currently in use. You can see that this is really amenable to a tablet where you can click on the drop downs to... Oh, what we're showing here is because this is a male, the obstetric history tab actually doesn't have anything in it. And currently in this sprint, we're working on an addition to entirely remove the header when there's no content, if that content is being hidden, perhaps because it's a female or a male. When you get to the end of the survey, if you have questions which you didn't complete that had asterisks beside them, you'll be forced to fill those out. And the way that we categorize it is if a formal report being generated requires a field for that report to be generated, we made that question mandatory. And that way it helps us ensure that the data we capture for government level reporting is always there and that we don't have gaps in it. I think we're just going to load the form here, and it's probably we're going to try to close the form here soon, and it's going to tell us that there'll be a few fields which haven't been filled. As you can see, this is a very comprehensive form as far as the number of fields available to be completed. The medication panel here, we're currently working on trying to do an actual formal medication order entry module so that we can integrate directly into pharmacy. And here, as you can see, this form provides the structure so that we can take a nurse or a clinical officer and really allow them to provide a comprehensive medical appointment for someone. Quick picture here. This is the X-ray truck. We now have 2 X-ray trucks. As you can see, there's a generator which powers it. And this is how we get X-rays out in the community sites which don't have X-ray capabilities. It has inside a standard X-ray beam as well as a receiver, and it sends the signal wirelessly from this panel to the laptop, where we burn onto a disk a copy for the patient, and we send a copy directly wirelessly to our server, and you've seen how it comes in through the PAC system. The truck also has other point-of-care diagnostics, and we're continuing to expand what it can do. Now, this here is a picture of our barcode printer, and in the HIV lab, in our central AMPATH building, the clinician can log in, print a label, put it on the label sheet, and also put it right onto the blood tube. And so that reduces any errors that could occur in that system. And here we're just looking at the systems from oncology because we want to integrate them as well. As far as some specific projects which are upcoming, the first is adding additional clinical functionality. As mentioned, we're always trying to design new modules, but in context of understanding how it ties into the bigger system. Meaning that when we create a new module, for instance, for population health, so that they can refer patients better, we try to build that in such a way so that when the cardiology program needs a referral module, which it turns out that they did, we're able to transport the exact same module into their system. Or we built this a few months ago, a patient survey module, and we were standing in line with the person who runs the quality assurance for the HIV program, and they said that they were going to begin running some patient surveys on paper. And so they found out that we had developed a patient survey module for the chronic disease program, and now we can enable that program to benefit from the other program's functionality. Or the other option is the oncology program will be doing a lot of work with improving our user interface, and all those changes will benefit every other user in the system. And so we have an incredible amount of synergy by bringing in actually new divisions into the AMRS POC system, and a few areas in particular which are cross-cutting across all departments are creating a full order entry system for medications to integrate from the clinician into the pharmacy, to expand the telehealth capabilities so that we can keep patients closer to home, and to continue to integrate more diagnostics and labs. The second area of major projects is expansion of the AMRS family. There are discussions currently to expand the number of sites that use direct point of care by converting those sites which are currently on the retrospective paper entry. In addition, we're looking to expand to mother-child health, to chronic disease management, oncology, population health, cardiology, dermatology, mental health, acute care, neurology. There are, we estimate, and JJ calculated this list kind of off the top of his head, and I did the same calculation off mine, and we both came to the number that there's at least 100 new clinical sites which there is reasonably high demand to be converted in the near future to point-of-care medical systems, which would actually take our total number of sites up by 5-fold. And that doesn't include potential expansion into a larger AMPATH network if they're based on sort of future grants in the coming months. Now, if we do expand the system so dramatically, an exceedingly high priority is to improve its stability and speed. In fact, the system really needs to have the capability of functioning in a semi-connected or offline capability. Fortunately, we've been able to have last year more than 95% uptime, but that is not good enough. We need to continue to improve our uptime metrics to make sure that it's always as fast as possible. And this leads into our last point on user training. As we add more people to the system, we need to make sure that it's easy to train new users. And we currently, this month, are integrating a video server service so that we can build into the application, every time you load a new version of the software, a short screenshot video training tutorial, just a minute or two, will play, which shows you the exact new features and how to use them. In addition, we can create an AMRS university so that new users can train themselves prior to our on-the-ground team going into a site to train new users. And last, data analytics. And this is an exceedingly important part of the core product and something which we have some very exciting work which is upcoming, which leads us to the second part of the presentation on dashboards and on data. What I want to do now is walk you through some of the existing dashboards that we have currently built into the system for HIV. The first here is the clinic dashboard. This is showing you at MTRH module 2 of the daily schedule. As you can see, you can configure this schedule based on departments, programs, visit types, or encounters. And it's showing us for the October 9th there, how many patients came in, what their average wait time was, what their triage time was, and how many touch time they waited for the clinician. And that's also broken down by time of day. And so this is a great page to see the metrics. We also keep a real-time list of those patients who have missed their appointment dates, and so that they can be followed up immediately by our retention staff. And so what I wanted to show you with these dashboards is that we're not collecting data just for the sake of data or to write a nice university paper. The point is that we can use it to really build a healthcare system and to drive care. This here is the monthly schedule, which we again separate into visits, appointments, and to pull out all those patients which have not been returned. If we were to click on that orange box with the number 17 in it, it would produce a list of exactly the 17 patients which missed their appointment that day, and then we could, through that list, essentially pull up the patient's phone numbers and contact them directly. This module here on active patient enrollment allows us to sort the number of patients enrolled into a program during a period of time. And so we're seeing here in Busia County that there was approximately 14,000 patients in the standard HIV treatment program since last October. If we were to click on the numbers in any of these boxes, again, it pulls up a patient list with the patient's name, their number, their phone number, and you can always click on that patient's name to pull up their full medical chart. So if you wanted to find, for instance, the number of patients in a particular program, very easy to do so. These is a clinic overview visualization going back to 2015 from the MTRH Module 2. It shows us during this time the trends in the number of patients in care on ART, the percentage on ART with viral load, and percent virally suppressed. We also display in the absolute numbers in this chart below. And as I said before, you could click on one of these boxes, for instance, if you wanted to know those which were not virally suppressed, and generate a report. These are tools which are available at the clinic level, meaning that any clinic in our AMPATH network, if the user has permission, they can go in and access their clinic's data to produce their own reports, to run their own queries, and to have ownership of the data and the metrics which came out of their clinic, which is really important to realize, is that this data is always accessible at the clinic level in our very distributed network. Here's another visualization looking at patient care status over a year, comparing the number of patients active in care, those lost to follow-up, those which died, those which were transferred out. Here's a more complicated monthly analysis, trying to compare our patients, and we have some cohort analysis tools as well. We'll move on here to the defaulter list. As I said, it's very important for us to follow up with patients who are no longer engaged in care because, if you don't take your HIV antiretrovirals, you develop resistance. And if you develop resistance, the price to treat you with second and third line treatments becomes much higher. And the system can't support treating too many more patients on second, third, and fourth line regimes. And therefore, one, it's better for the patient, and two, it's better for the system if everyone can stay active in treatment. And so we can generate a list of patients in that clinic who have defaulted, meaning that they're no longer active in care. We'll move in here to the MOH 731 report. This is a very important government level report. And so we can generate this now on a monthly basis. And in fact, each clinic goes in and can pull up their own MOH 731 report. It's formatted in a way which complies with Ministry of Health standards. And this is a really important tool that the Management and Evaluations Department uses to track HIV care in our system. And the important thing to realize is that this is government level data. And so it validates the quality of the data which is coming into our system, in that this type of a report is trusted. The HIV summary indicators is meant as a sandbox. And here any clinician can go, provided they have access, of course, the data analytics component of the system, to create their own queries. They can choose from this list of indicators available, sort by time frame, by age and gender, and then what it will do is search the database to produce a report on the indicator selected. As you can see, it takes a while to load. And on this particular visualization, I wanted to show you how long it actually takes to load a report. On the other tabs, admittedly, I had preloaded those pages, and so you didn't have to wait for them to load. But keep in mind how long this process takes, because when I show you a new tool in a little time from now, you'll be amazed at how much faster the new tool we use for data is compared to this old system. And here we are. We see that in MTRH Module 2 over the last year, there was about 4,500 patients, of which 26 were pregnant on ARVs. And so this tool is flexible, and you could ask your own clinical questions. The patients requiring viral load is also, again, an important thing which we follow up on, and so you can generate a list. And this here is actually a brand new module, just introduced in the last few weeks. It's not even fully operational, but it allows you as a program to go in and to view all those patients that were referred to your program in your facility, or those which you've referred out, or those which are currently in a program. And this will be used as we develop a more advanced referral network throughout the AMPATH Population Health Network, as a way to see who's been referred to a secondary level care facility. And so this is literally just being rolled out, and I think last Friday at the sprint demo, this was part of those programs. Now, that's the current system, but we've been working really hard over the last several months to take our data analytics to the next level. And the way which we want to do that is using the Elastic Stack, and specifically a product called Kibana. We have to thank Elastic Stack for donating a license of their enterprise software to AMPATH, and we hope that we're putting it to good use. The big advantage with Elastic Stack and Kibana is that the way that Elastic Stack structures the database, it can be queried incredibly quickly, exponentially quicker than the traditional MySQL database that we have before. And so as we move into these era of big data, tools such as Kibana are popping up, and we are excited that we're able to integrate it into our AMPATH system. Now, what I would like to do is actually go and do a live demo of this tool. And of course, doing a live demo, let's see how this works. We'll see how this works. This is Kibana, which we've logged into. And now the first page we have here is our MOH 731 report. So this is all real-time data for that report. But what we can do is we can go in and we can filter this report by county, by time, and actually all the way down to specific clinic, and produce the report. And let's see how fast it is to filter. There we go. Done. Updated for the Turbo Clinic. That query would have taken, as you saw in the previous slides, a little while to compile, but we have now already completed that query. You can also review the report, for instance, in graph form. And if we were to go and look at a specific indicator, for instance, if we wanted to look at screen for tuberculosis, the way that we've created this visualization is we have a graphical form, we have the table form, and then we actually have a patient list. My computer's network is slow today, but here we have patient level data. And if you actually clicked on this patient, it would open them up in our medical record system. And it's really cool how integrated it is. I want to show you another dashboard here, which is called viral load analysis. And on this dashboard, we're able to track how well we're doing across these particular indicators. You'll note that we're able to create very simple visualizations, which you could imagine anyone in the clinic following up and using, as well as more complicated visualizations where we can set targets and see how we are deviating from that target over time. And again, all this data can be filtered by county in minimal time. Let's just clear this form. And we have here let me open up actually the comparison by county, because I think that's a particularly, we have our unsuppressed analysis where we visually display on a map where those patients who have high viral loads, wow, the internet's slow, everyone must be on Netflix, are coming from in our network. And here on the comparison by county, we can actually compare over time all of the clinicals, or at least the high volume clinical sites, to see how they're comparing against each other. And I want to show you one more dashboard, which these dashboards are just being made in the last number of weeks. They're not that old. We're still new at this. And I think part of it's timed out. So this here is real time, as when I loaded this page a few minutes ago, real-time dashboard of the HIV AMPATH network. And you can watch this data filter in real time during your clinic day. We currently see here which sites had the highest volume. Of course, Eldoret and Busia were very high, as well as Kitale. In this part of the graph, we can see the encounters per hour. On the green, we see exactly what time patients were triaged. And then in the blue line, we also see what time they had their clinical appointment. We can see the patients per hour in total. And so here we have a dashboard showing the average time it takes to complete a clinical encounter in the number of minutes, separated into the time for the actual clinical encounter and the time to be triaged. And you can use a tool like this to see perhaps which clinics are performing really well. You may want to focus in on that clinic and try to understand, is there something in particular they're doing well there that we should share throughout the network? And then you can see those sites which actually have much higher wait times and maybe you want to avoid. What I'm trying to show you here with these dashboards is that we're not just building a data warehouse. This here, AMPATH, is building and builds healthcare systems. And these are the type of metrics which you can use to really drive and refine that system. Here we have a list of all the clinics and the number of patient encounters. And again, here today we have which programs were most common as far as the number of patients who went through those programs with clinical visits. What we're going to just skip over, because it has some names of clinicians in it, is a table which shows the number of forms or the number of patients essentially seen by each clinician. And so you can, if you were the clinic administrator, see which people are seeing a lot of patients and maybe which is taking a longer tea break. And here we have a list of the encounters by type, based on the most popular encounters down to less common encounters. And we have the time to complete each encounter type, and you can see you could almost do A/B testing where you build two different types of encounters to do the same follow-up type visit, and you could see which encounter takes less time and compare the outcomes of those encounter types to see how you could really fine-tune your system. And then at the end, we have the patient list. And so just like the other forms, you could click on a particular patient and pull up their file. Now, what we can do, just to show you how quickly the system works, is I can go in here and select, where's the breast cancer? This wasn't really a breast cancer program. This was more of a actually, every day these metrics are different. So it looks like no one yesterday was in their HIV appointment screened for breast cancer, which kind of makes sense. But sometimes there are a number of patients. For instance, if we want to look at the number of patients which had youth returns yesterday, I don't want to use death reports just because there's one patient, so I don't want to pull out their data too specifically. But you can imagine using this type of an ability to drill down to a particular encounter type to see if there's a trend or an epidemic happening in the system. But if we pull up this one here, for instance, on where people had differentiated care retention appointments, all we do is we click filter for value, the system sorts, and then there we go. The day has been filtered. We can see exactly where those appointments occurred on our map. We can see actually when those people came to clinic, the clinics that they went to, how long those encounters took, the particular clinicians which saw those encounter types. And it's, as I said, this is a really powerful system. And we're excited to be able to use it now, now that we've integrated our data sets into Kibana and Elastic Stack on our, and I think the possibilities are really endless on how this is going to change care. We're actually hoping to develop some visualizations which show the entire AMPATH network and the work which is being done here and put them out on a public global link so anyone can see and watch them in real time to see what's happening. When AMPATH said, as I said, that they're developing a system, they really are trying to develop a system. And I think this type of detailed data proves the ability to deliver on that promise. And a key focus this coming year is to ensure that everyone, from patients to providers to clinics to counties, have access to the data. And so for a patient to be able to see the trend in their viral load dropping as they take their medications is incredibly important. And for a physician and a provider and a clinician to be able to see the effectiveness of their care within the clinic, to see the trends on how many patients are following up is very useful. And for a clinic or a county to know that each dollar they're spending is being used well is available and possible with the type of data which we have in our system. And on a global level, what we're looking to do with this system is ultimately not just keep it within HIV, but to build out the exact same systems for oncology, for population health, and to our other departments. Now, there is one more thing. You can't go to a conference or talk without talking about machine learning. And so we have to talk about machine learning. Now, for those who aren't familiar with machine learning, in short, it's the ability of computers to teach themselves a specific skill. And this is in contrast to past ways where you would have to program a computer step by step. The advantages with machine learning is that machines can learn by their own skills which would be far too complicated to program into a computer. For instance, it was said for many years that you could never program a self-driving car, to turn left, because the number of variables you have to take into consideration to turn left is far too many than you could program in. But through machine learning, we now have the ability for essentially cars to drive themselves. Or similarly, the voice-to-text ability that you have on your phone, where you can dictate into the phone and it writes the words for you, is really possible, the fact that it works well, through machine learning. And so there's much hope that machine learning will help assist in medical care. And the ability to do routine diagnosis and routine management of clinical care through a machine is incredibly exciting. And it has potentially the greatest impact on resource-limited settings. Because the moment that you can do routine diagnosis and routine care on the computer, you drop the cost of that care, at least for the diagnosis part, to the cost to move electrons, which is the cost of doing a Google search, which in some ways is actually free. And therefore, I believe that machine learning, machine-assisted care has the potential to really solve the problem on how do we deliver healthcare to the 5 billion people which don't have access to a physician to do their diagnosis and care management. Now, AMPATH, as we discussed, has an extensive and very high-quality data set. As you saw in those forms, we capture this data as discrete data fields. We actually have very little free text in many ways. For its, it has advantages and disadvantages, but that's just the reality. And so we are actually working already with researchers from NIH, Regenstrief, Brown, UCSF on ways that machine learning can assist our clinicians and patients. 2 examples. The first is a project where we are trying to predict HIV viral loads with the hope that if we could predict what a patient's viral load will be, that we'll be able to optimize when they should have repeat testing and follow-up. The second is a project trying to interpret chest x-rays as normal or abnormal. And that way, we have the x-ray truck and we can get the x-rays, but there's sometimes trouble finding a radiologist to read them. And so if we could use a machine to help us categorize whether the x-ray is normal or abnormal, it would make it much easier if the radiologist only had to read the abnormal images. And then we want to use machine learning to really help provide clinical decision support on how they should follow up on these image results. AMRS is working very hard on trying to improve its stability on the needs of today. And so we don't want to get distracted with machine learning at this time. It's a very appealing thing. We are focusing on our core user problems very strongly, but down the road, I do believe that machine learning is going to play a strong role in the delivery of our healthcare system, and that AMPATH is perfectly positioned to innovate and reap the benefits of this new machine learning age of healthcare. And one more thing, AMRS 3.0. AMPATH has grown significantly from a system which treats HIV to trying to build a comprehensive population health program. And as we grow to bring on non-communicable diseases, oncology, and more users, we have the question to step back, take this opportunity, and figure out if we could build the perfect electronic medical care record that could integrate care for our patient, how it would work. And we're calling this vision AMRS 3.0. And this is actually a whole separate talk. It's available on YouTube if you Google Gregory Schmidt, OpenMRS, electronic medical records, or EHR from foundational design principles. You'll find it on the YouTubes. But the point I wanted to show here is that we are thinking from first principles. How would you construct a user interface where you could multitask and which would think about data the way that physicians think about data, would really make a simple user interface that you can go deeper into having more detailed data as you need it, and to produce something which is beautiful and that users want to use. And ultimately, a system which, as I said, allows a patient to come in to one clinic, but to not have their care fragmented, meaning that when they come in, they can have, for instance, their HIV appointment, their nutrition appointment, their hypertension appointment, and their tuberculosis appointment all integrated into one encounter. And so there's a whole other presentation on that, and I could talk for days. But this is something which is a huge undertaking. We also, of course, have to make the system work offline. And we need more help. And so we've reached out to the OpenMRS community, to Partners in Health, and the other groups which are also trying to build comprehensive care systems, and with the hope that just as we worked together 15 years ago, we can continue to do this as we try to take the system to the next step. And so, in conclusion, I would like to thank the many contributors over the years who have helped build the AMPATH medical record system. Our current team continues to push the envelope in ways which we can expand it, to act better upon the data, and to help physicians and clinicians have the best tools at their fingertips so that they can help patients heal and flourish. I think a lot of the magic of the AMRS system is that at AMPATH, we were able to combine the development of the electronic medical record in real time with the clinical care delivery system. And this to me is crucial because there are groups which try to build electronic medical records and there's groups which try to do innovation in system design. But if you have these two different groups in one organization under the same roof, you can do so much more. A very quick example, a few months ago it became apparent, just a month ago it became apparent that we need to improve one of the indicators on how we manage patients here at AMPATH with very high viral loads. And so within 48 hours, the clinical teams and the IT teams had gotten together to develop an enhanced HIV program for patients with viremia or high viral loads. This program then went from the group on the ground, which developed it, all the way up to the top administration within our AMPATH program to approve it. And then it got built into the system in the coming few weeks. And so we were able to move very quickly to build both an entire clinical program and an entire program into the medical record system, working together like this. And this is, I think, also where the data comes into the picture, because ultimately we're collecting data to drive a system performance, and that data collection comes, as we saw, from the clinical encounters. So by trying to connect all these dots together as we do at AMPATH, we're able to do some really cool work. Just to summarize today, we've looked at the evolution of the medical record system from a place where you have a lot of problems with paper records. We looked at how OpenMRS was innovated out of Eldoret and now has become worldwide, and how in the last 3 years we've implemented a point-of-care system for real-time use with over 60,000 patients, and how we're growing, and it looks like we actually have to expand the number of clinical sites by at least 5-fold in the coming future, how this system provides fully integrated care to the patient and is supported by a really diverse team here in Eldoret, program managers, developers, form creations, network team. And we're able to build out of this large project some pretty powerful data that can be acquired in real time and made accessible to users. And as we look to the future, we're optimistic to think about how we can rebuild a new system with a better user interface, which harnesses the ability to provide population health care, which we mean integrated care, not just isolated to HIV, but which takes care of the whole person's health. And we think that machine learning will help provide care which is accessible, higher quality, and lower cost. I'd like to thank everyone for following along on this presentation. And if you have any ideas on how we can improve our system, things that you hate about the system, please contact me. My email here is gschmidt, schmidt, at ampath.or.ke. And perhaps in a year, I'll repeat this presentation and hope that there are some updates that we can improve in the history of the medical record system. Thank you.